Ladies and gentlemen, first of all, I'd like to thank for the invitation. I was asked to give a presentation about the deairing devices in mini bypass circuits, and I found out that it's a real difficult task. Anyway, you have seen in the former presentation this morning that air, emboli, bubbles, microbubbles, mini bubbles is a real problem in many regards, and we all know these problems also, of course, from diving with Casson's disease, from anesthesia, neurosurgery, and of course in cardiac surgery where air can enter the circuits from the perfusionist side, but also, of course, from the surgeon side. This morning also has been differentiated the microemboli from the macroemboli, which we see in various settings, and it has also been told that microemboli are not only gaseous, but can also be solid particles, and there are many ways to prevent solid particle dislodgement, and I won't go into detail with that. I will only be speaking about gaseous emboli. And these causes for microembolism are, of course, manifold. You all know this. This is nothing new. There is adhesion of bubbles on artificial surfaces whenever you perfuse some artificial circuits. When you infuse drugs with cardiotomy suction and with temperature gradients, it's like opening a lemonade bottle. You always get some bubble problems. And it has also been alluded to this morning, the consequences of emboli can be very, very manifold. There can be totally asymptomatic, even though many bubbles go into the capillaries and make some degree of an organ ischemia. You may also see in many patients which have elevated enzymes despite having quite a normal outcome. There can be some neurocognitive impairment, which is not infrequent in cardiac surgery. You all know that. But there can be also very severe consequences up to stroke and disabling. Now coming to the mini ECC, this is the circuit, the Mackay system called MEC system, which we use in Regensburg on a routine basis. It's very, very simple and very basic. It consists only of two components. There's the Rotoflow centrifugal pump and the Quadrox oxygenator. For this mini circuits in the sea, it's a very small setup. And we use this system, of course, because we see quite a lot of advantages with this. We don't have any arterial and venous filters, even that is the topic of my presentation, and no venous reservoir. And we think the advantage is of this system that it has a very low priming volume, and because there is a low priming volume, we see almost no inflammation, no cells, and that's why we see such a good outcome with these patients. And therefore, we use it routinely, as I told you. You see here the red bars. This is the increasing experience with these minimized cardiopulmonary bypass, which now consists of about 40%, which is the same as the standard cardiopulmonary bypass, and the standard are the training cases and the combined cases with the valve surgery, apart from a 20% OPCAP. So we have now experience for more than 1,500 cases with this technology. And we use it also quite frequent for ECMO, for all kinds of ECMO, arteriovenous, venovenous, and even for air transportation. Every now and then we even get patients from the Iraq and Afghanistan war to bring them up again for blast injuries of the lung, and this is also done with these mini circuits. So now coming to the main question, how avoiding air problems in these mini circuits. Well, the first, and that's what we rely totally and mainly on, is air-free handling, which just means to connect the components by perfect air removal. And that's all we do. Nevertheless, you can add quite a lot of technology, and the most commonly used is the venous bubble trap. Venous bubble traps are small components which are added after the blood leaves the patient, that's here, before it enters the centrifugal pump. This is on the left side the Mackay system, and if you look at the circuit, it's here, it is just prior to the entrance of the Rotoflow pump. Now, how does it work? It's a very simple principle. The blood enters from the right side, in the centrifugal flow, and because of buoyancy and gravitation, the blood goes down and exits here, while the air bubbles are eliminated on top. But what you see here is the priming volume of 160 ml, and if you look at our basic priming of a 500 cc, so it adds quite an amount of priming volume. Of course, there are all other brands which basically work the same. This is the Terumo Cabiobs bubble trap, which is available also in a pediatric size with much lower priming volumes, but the pore filters, which play a less important role with 170 microns, are about the same. And there are also some integrated system like this one. It's a cardio bleacher delivery system, integrated heat exchanger, integrated bubble trap, and the same low priming volume and a micron filter, which is much lower here. In a various setting or in a specific setting, these bubble traps can be very effective. And this is nicely shown by the Albers group of Brandenburg, who shows a reduction of arterial microbubbles when putting in these venous bubble traps. You can see it here. The gray bars is the control group, and the black bars is the deaired group with the venous strain. They show in this paper it was highly effective. The second thing you can add is on the arterial side, an arterial bubble filter. Here you see the schematic drawing again, the bubble track as the first component and the arterial filter as the last component, removing the remnants before the blood enters the patient. Again, here the setting in the reality. After the blood has passed the oxygenator, it comes to the arterial filter and goes back to the patient. The manufactured Marquet system also has the same disadvantage in our mind with a 180 ml cc. So if you add a venous bubble trap and an arterial filter, you can easily double the priming volume. And that's what we think a disadvantage. Otherwise, it's fairly simple, and there's a second thing from Terumo. It's about the same and also available for the pediatric size, but there's quite a large maximum blood flow rate, which makes it easy handling. A very peculiar system is the so-called dynamic bubble trap. This is a study from Germany by Bevensen, where they used this bubble trap, and the traps, you see in the next slide much better, are via these triple helix are collected in the midstream and exit here. They also found quite a reduction of microembolic signals integrating these bubble trap. And here is another German paper from the Nauheim group where you see how it works again. Here are the bubbles which are collected in the midstream and then removed. And their data also show it to be quite effective. Here are the numbers after the trap are considerably lowered, and also the hits are somewhat lower. But in total, to summarize, the dynamic bubble trap, of course, cannot prevent, but it's a helpful tool to reduce the total embolic load. And since the serum 100 protein was lower, it may also be kind of a protective system for the cerebrum. We also, in our institution, did a series of experiments with a bubble counter, ultrasound detection, and we looked for the bubbles in a size up to 205 micron, which is quite a large spectrum. And we compared a couple of different systems. This was the standard ECC. The blood is collected in a venous reservoir, roller pump, arterial, oxygenator, the quadrox and the halide, arterial filter, and back. So this is a normal standard cardiopulmonary bypass machine. And you see here the priming volume is about 1200 mils. Our miniaturized system, where the blood goes through the venous line to a pump, which is mainly the rotor flow, but also a delta stream, and via the quadrox or halide back to the patient, has a priming volume of only 500 mils, which is quite low. And another more integrated system where all components are into one setup to perfectly eliminate the bubbles. Here you can see there's a venous bubble trap with an active air removal system, also called a mini circuit because there's no reservoir, pump, oxygenator, and an additional arterial filter. So this is kind of a mini bypass system with all the filters and bubble traps possible. It has a priming volume which is even larger than a conventional machines. Now here's a more close-up view of this active remover air system. So what did we find? The measurements showed that the bubbles were in quite a large spectrum from very small bubbles up to here. And when you see where the filter sizes were from the meshes, the bubble trap was about here, and the arterial filters were about here. So the majority of bubbles just are able to pass all these filters. And as a consequence of that, we saw quite surprising results. You see here the standard ECC is the quadrux here. The standard ECC is just in the midline. The resting heart system, the mini ECC with all the filters and bubble traps, was extremely good in eliminating the microbubbles, while the Meadows Precise system did much worse, and the Mackay MEC system was about the same than the standard ECC. So that was our clinical experience before. And when we now added up these venous bubble traps, by surprise, we found no difference. So the conclusion of our personal experience was there is a great variability of microbubble activity, and that the mini bypass circuit bubbles are quite comparable to that of standard ECC. In our hands, the clinical outcome is quite similar, and the effectiveness of these venous bubble traps is questionable. It mainly depends on what the remainder components of the circuits are. So the overall conclusion of this presentation must be that there is certainly a benefit from these venous bubble traps and arterial filters, but for the short-term and intermediate-term use in the mini circuits, this benefit probably remains quite unclear. Thank you very much.
Thank you, Christoph, for this nice overview and also for staying in time. This paper is now open for discussion. Are there questions from the floor? I'd like to ask you, Christoph, my first question is, does size matter? I know that most of the females can answer this question, of course, but I mean, does size of the air bubbles matter? I mean, is it not a question whether those bubbles occur in the circulation or whether they can be eliminated from the circulation? To my understanding of a mini bypass system, the big beneficial effect causes from the circumstance that not so much high volume microbubbles can be formed within the circulation. So that means that they don't need to be eliminated because they purely do not exist in the mini circulation. What do you think about it?
Well, actually, nobody knows. In our experience, we found such a quite variability in size that we cannot argue that the size is different in ECC and mini ECC. And we also cannot prove that smaller bubbles are less harmful than larger bubbles. We only know that larger bubbles are more effectively to be removed from a circuit. The only thing we saw that the systemic inflammatory component was very important. But with regard to air bubbles, it's almost impossible to prove what's origin and what's consequence.
Let me ask in another direction. How sure can we be that air bubbles occur in a mini system the same way as they occur in an open system?
Well, we measured it just in the arterial line prior to entrance of the patients. So The net effect of the whole system is summarized by this measurement. And if we found the same amount of bubbles, at least or the total volume of bubbles, it's about the same. We didn't go into quantification of every size of the bubbles. This was not done in this setup. But the fair amount of the total volume of microemboli is about the same.
Do you think we should distinguish between the kind of the operation? I mean, is it necessary to have venous bubble traps and arterial line filter in closed procedures like bypass procedures, or is it just important for open heart procedures like valve operations?
Well, we don't do valve procedures with mini bypass because we think the great advantage is to have a closed system. And because we have the majority impact in the systemic inflammatory response, which is surely better if it's a closed system. But if you do open heart or aortic valve replacement with the mini circuits, I personally would always put in a venous bubble trap, which probably is the more effective part than the arterial filter.
Alex?
Thank you for a clear presentation. I have one question. Now you showed us that the venous bubble trap is not very efficient in the routine setup. But what about safety? Do you think it should be in there as a safety feature? It could be non-operant in sort of closed cases, but isn't it necessary as a safety feature?
Well, in our hands, it was not very effective because our system obviously works quite well without the other investigators found a tremendous effect of the venous bubble trap. So the same is with the safety. I think the best bubble trap is worthless if the perfusionist is not good. And if you have a very good perfusionist, probably you don't need a bubble trap. So safety depends on a bubble trap and on the perfusionist, on both systems.
And the surgeon, of course, yeah.
The more you miniaturize the system and the more easy you make it, the more good people you need to support you.
Sundar Ramanathan from India. I enjoyed your presentation. In conventional extracorporeal circulation, it is known that there are certain steps in the operation where the maximum particulate load is high. For example, aortic cannulation, looping the aorta, clamping, clamp release, and as you go on bypass onto the venous side. Does in the miniature circuit, is there any different when you look at the hits, or is it the same like conventional bypass?
Well, the problem in that is that you mix solid and gaseous particles. And the most of the particles you can detect with transcranial Doppler sonography, with aortic clamping and declamping, all that stuff. That's quite often also solid. Or at least a major part in many studies done. So I wouldn't compare these data with our data because that's like comparing apples and pears.
Thank you.
Okay, are there more questions from the floor? If that is not the case, we proceed to the next presentation. Thank you very much again. The next speaker will be Dr. Mulholland from London, who will give us a critical